So depending on when you actually watch this video, you may actually watch this video by the time we reach 5,000 subscribers. At the time of recording of this video, we had 4,989 subscribers, meaning that we have only 11 people to reach 5,000 subscribers. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be pretty much looking at the fetal circulation as a stepping stone as part of Cardiac Week, when we're going to be looking at pediatric cardiac congenital anomalies. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment, get your piece of paper, get your pen, and let's go. So I started off with adding an image to this lecture because most of you actually say that we're visual learners and sometimes we don't really get your explanations. So I will explain first the overview of the fetal circulation. We'll go through the notes, and then after which we will conclude the lecture. So there are a few things that you should actually keep in mind whenever you are talking about the fetal circulation. The first and foremost thing that I want you to keep in mind is remember that inside the uterus, in the uteral environment, the uterus is a relatively hypoxic environment. Now, this uterus, which is relatively hypoxic, it's because the fetus, number one, isn't really using the lungs. The lungs are not really functional because they're filled with fluids. They're not really expanding, and they're not really working, quote unquote, for the gaseous exchange that they're supposed to do. And in addition to this is why there are certain mechanisms that have to be put in place to maximize as much oxygen as possible for the fetus. The second point that I want you to keep in mind is that the blood vessels in the lungs respond differently to hypoxia as opposed to the blood vessels in the system. Remember, in a child that's grown and is born out of the fetal circulation, the lungs are functional. And the whole purpose of the lungs is to oxygenate the blood. So pretty much blood is not going to flow to an area where there is no oxygen in the lungs because it will be wasted. So whenever there's hypoxia in the lungs, the blood vessels in the lungs tend to vasoconstrict. And remember that vasoconstriction is pretty much going to lead to increase in pressure, blood vessel pressures. Then on the other hand, when it comes to the organs, remember that organs need as much oxygen or enough oxygen. If there's little oxygen, you have to maximize the little that is there. So systemic blood vessels or systemic vasculature are going to vasodilate in response to hypoxia. The opposite is true when oxygen is present. So remember, when vasodilatation is happening, the pressures in that blood vessel are going to reduce. Keep this point in mind. So remember that in the utero, the lungs are not really functional, meaning that they're not really working, they're not really oxygenating. The blood vessels that are there in the fetal lungs are pretty much going to be vasoconstricted. So it means that the pulmonary pressure is going to be quite high as compared to the blood vessels in the rest of the system, which are going to be vasodilated. And this is going to result in a lower systemic pressure. So in utero, the pulmonary pressure is higher than the systemic pressure. And this is one fact that is going to help the fetal circulation because blood is going to be flowing from an area of high pressure, which is pretty much on the right side, that's pretty much the pulmonary circulation, to an area of low pressure, which is pretty much the systemic circulation. So we'll start off with what's happening at the placenta, because I find it very easy to start off from here. Remember that the placenta, the fetal maternal unit, is what's going to be responsible for the exchange of waste materials that are coming out from the fetus in exchange for oxygen and some nutrients that are coming from the mother. So remember that blood that is rich in oxygen is pretty much going to be carried towards the fetus via the umbilical vein. So remember that this umbilical vein is pretty much going to be carrying oxygenated blood. Remember that the umbilical vein or veins are generally going to be carrying deoxygenated blood, but the umbilical vein carries oxygen-rich blood. So it's going to be carrying oxygenated blood through the umbilical cord into the child, and this blood is going to be draining via a shunt. So there's a shunt that bypasses the liver. So 2/3 of the blood actually bypasses the liver and uses this shunt, which is known as the ductus venosus. And 1/3 of the blood is actually going to be flowing through the liver, but eventually is going to drain into the hepatic veins. Then eventually they're going to be draining into the inferior vena cava. So it means that in the fetal circulation, the inferior vena cava is going to be consisting of oxygenated blood. Now this blood that is now in the inferior vena cava is pretty much going to reach the right atrium. So once it reaches the right atrium, remember that there is another shunt, which is known as the foramen ovale, which is between the right atrium and the left atrium. So most of this blood is going to be flowing from an area of high pressure to an area of low pressure across this foramen ovale. So from the right side to the left side of the body. So most of the blood is going to be flowing through this direction. Then some of the blood is of course going to go through the normal route. It's going to go past the tricuspid valve into the right ventricle. From the right ventricle is going to be pumped out through the pulmonary trunk. But there is another shunt that is present again between the pulmonary trunk and the arc of the aorta. You call this as the ductus arteriosus. So this ductus arteriosus is kept patent by prostaglandins that are being produced inside the fetus, and this is going to be shunting blood from the pulmonary trunk to the aorta, bypassing the lungs. Then of course blood that's in the aorta will circulate to the head and the rest of the body, and then eventually this blood is going to find its way back to the umbilical cord. Remember, this blood is going to be flowing and eventually reach what we call the internal iliac artery, which is a division of the common iliac artery. So this is the common iliac artery, the right, and actually the left and the right. Then from the internal iliac artery, you have an anterior branch where the umbilical arteries are going to be branching off from. And remember that even though these are arteries, they're going to be carrying deoxygenated blood. So predominantly, most of the aorta is going to be carrying deoxygenated blood. So this blood is taken by way of two umbilical arteries to the placenta, so that's the waste from the fetus can actually be exchanged. And remember that when you cut the umbilical cord, you're going to be visualizing two arteries and a vein. It looks like a face. So two arteries and a vein that is surrounded by the Watten's jelly. So this is pretty much the fetal circulation in an overview. So remember, like I said, in utero, the fetus has non-functional lungs. The pulmonary vasculature and the systemic vasculature are going to respond differently to hypoxia and to oxygen. Pulmonary vasculature vasoconstrict in response to hypoxia, whereas the systemic blood vessels are going to be vasodilating in response to hypoxia. The opposite is true when you have a lot of oxygen. So the pulmonary vasculatures are going to vasodilate in response to oxygen, whereas the systemic blood vessels are going to vasoconstrict to prevent, of course, the oxygen-related damage. You can form these free radicals that can actually damage the tissue. So even too much of anything is bad. So remember, vasoconstriction is going to lead to an increase in resistance, whether systemic or pulmonary. Vasodilatation is going to lead to a decrease in resistance, whether pulmonary or systemic. Then in the utero, the pulmonary resistance is going to be far much greater than the systemic resistance because the lungs are non-functional. And this is what's going to be helping blood go across those shunts, blood going across the foramen ovale, blood going across the ligament arteriosus. So when the child is born actually, and they take their first breath, the lungs become functional. What will happen? The blood vessels in the lungs will vasodilate. The pulmonary resistance will begin to drop. So this now, as it drops and it's going to become less than the systemic resistance, this is one of the triggers that's actually going to be causing some of these shunts to actually close. Now remember that the fetal circulation is going to be specifically designed to bypass the non-functional lungs in the fetus. And by roughly around the 3rd month of development, all the major blood vessels are going to be present and are going to be functional. And remember that the heart, how it develops, it starts off as a single chamber, then eventually it will divide into the 4 chambers. So that's going to be happening roughly at around 6 weeks of intrauterine life. And the fetus must have blood flow to the placenta. Remember that the placenta is going to be the one that's going to be facilitating gas and nutrient exchange between the mother and the fetus. And remember that maternal and fetal blood do not mix. during the pregnancy. Then resistance to the blood flow is going to be high in the lungs, and then in the pulmonary resistance is greater than the systemic resistance. I've labored so much on these points. Now, what is this fetal circulation if we go through the notes? So remember, you have a pair of umbilical arteries, which are pretty much going to be carrying deoxygenated blood and waste to the placenta. These umbilical arteries are going to be coming from the anterior branch of the internal iliac artery, which is of course a branch of the common iliac artery, which is a branch of the aorta. So these are going to be carrying deoxygenated blood and waste materials to the placenta. Then the umbilical vein is going to be carrying oxygenated blood and nutrients towards the fetus from the placenta. So 2/3 of this blood, like I said, is going to be from the umbilical vein. It's going to be entering into the ductus venosus, which is pretty much a shunt that bypasses the liver. Then it's going to be placing this blood into the hepatic veins, which eventually drains into the inferior vena cava. And then it's going to be joining the portal vein with the inferior vena cava. Then remember that the inferior vena cava in utero carries oxygenated blood. Then some of the blood from the umbilical vein is going to be entering into the portal circulation to allow the liver to process some of the nutrients. And then this blood is also going to be draining into the inferior vena cava. Then from the inferior vena cava, this is going to be draining into the right atrium, and then is eventually going to be passing through a shunt, which is known as a foramen ovale, from the right atrium to the left atrium, bypassing the lungs. Then more than 1/3 of the blood actually takes this route. Then some of the blood actually passes past the tricuspid valve into the right ventricle, and then it's pumped out through the pulmonary valve into the pulmonary trunk, but most of this blood is going to be shunted into the aortic arc by the ductus arteriosus, which is pretty much going to be a connection between the pulmonary trunk and the aortic arch. Then of course this blood flows to the rest of the body and back to the placenta via the umbilical arteries, which are pretty much a branch of the anterior branch of the internal iliac arteries. Then of course the shunting of the blood past the lungs is made possible because of the point that I keep stressing. The pulmonary resistance is going to be greater than the systemic resistance. But when this child is born and they take their first breath, the systemic resistance becomes greater than the pulmonary resistance. Then of course this closes the shunts. So this is an image again. Once more, you may pause it here and I think you understand now, and you may take a screenshot of the fetal circulation. Now remember that the foramen ovale is not going to remain open forever. It's going to be closing shut after birth. It fuses completely within the first year of life. Then the ductus arteriosus is going to be closing soon after birth, so roughly around 7 days, and it becomes the ligamentum arteriosum in about 3 months. The ductus venosus is going to close and eventually become the ligamentum venosum. The umbilical arteries are going to become the medial umbilical ligaments. Then of course the umbilical vein is going to become the ligamentum teres, which is pretty much going to be dividing the GIT into the upper GIT and the lower GIT. Remember that the defects in this fetal circulation or development of the heart are what's going to be leading to congenital heart defects, which are pretty much giving a stepping stone to what we're going to be discussing on the channel as we look at Cardiac Week. So these are actually the most common causes of heart disease in children. You have about 8 of them in every 1,000 births. They range from a wide range of presentations. They may just give you these asymptomatic murmurs. Sometimes you may have severe congestive heart failure immediately after birth. And they arise during embryogenesis. So usually they're going to be arising between the 3 to about 8 weeks of gestation. And remember that these congenital heart diseases are going to be as a result of 2 to 3 mechanisms. It's going to be a result of shunting of blood from the left to the right, as well as shunting of blood from the right to the left. Sometimes it can even be due to a certain obstruction to the flow of blood. So remember that the right side is going to be low pressure, low oxygen. This is, of course, happening in a normal circulation when the child is born. The left side is going to be consisting of high pressure, high oxygen. And remember that once these two sides mix, this is going to be reducing the oxygen concentration, and this is what can actually result in symptoms. Now, in patients that normally have shunts that are causing blood to move from the left side to the right side, they may be relatively asymptomatic until later on in life when this shunt begins to reverse. This reversal of the shunt is known as Eisenmenger syndrome. We'll talk about it in a whole lot detail when we look at the different congenital heart diseases. There is actually increased flow through the pulmonary circulation, which results in hypertrophy of these pulmonary vessels and pulmonary hypertension. And this increase in this pulmonary resistance is eventually what's going to be causing the reversal in the shunts. This is going to later lead on to cyanosis. It's going to lead to right ventricular hypertrophy. It's going to lead to polycythemia. It's going to be leading to fingernail clubbing. And of course, defects with right to left shunts usually are going to be presenting with cyanosis because oxygenated blood is being mixed with deoxygenated blood. Now, when you talk about congenital heart disease, this is just pretty much a group of diseases that are going to be involving malformations of the heart as well as malformations of the major large blood vessels. So in common usage, congenital heart disease actually is going to be referring strictly to like structural heart defects that are present at birth. They're going to be accounting for about 1% of all the births, but the incidence is actually much higher in children that are premature babies than those that are term pregnancies. There are three main categories that we're going to look at. The left to right shunts. This is where blood is going to be shunted from the left side to the right side. So deoxygenated blood is going to be mixing with oxygenated blood. Then, or rather, oxygenated blood is going to be mixing with deoxygenated blood. Then you have the right to left shunts, where now the deoxygenated blood, which is meant to go to the lungs, is going to be now mixing with oxygenated blood. So this is going to be causing cyanosis. Then we have obstructive type, which cause some form of obstruction. So remember, a history, physical examination, a chest x-ray, an ECG, and echocardiograph can actually help you in identifying the presence of congenital heart disease, except in early newborn period where the diagnosis is actually quite challenging and it may sometimes be just an incidental finding. Remember that palliative or corrective surgery is feasible for most patients with congestive heart disease, provided if it's undertaken in a timely and a quick manner. Then we have a substantial proportion of these patients that have congenital heart disease that actually have significant problems with other organ systems. They have certain chromosomal or even single gene disorders. Then of course, many of the children are going to require follow-up lifelong for the rest of their life. Then what actually does cause congenital heart disease? This is just pretty much an overview. You may have genetic and environmental factors that have been implicated. Only 10% actually can be linked to a definitive etiology. So there is a common association with certain chromosome abnormalities like trisomy 21 and Turner syndrome, which is monosomy X. You have these endocardial cushion defects, which are going to be resulting in atrial and even ventricular septal defects. You may have atrioventricular valve deformities, which are frequently associated with Down syndrome. There may also be an association with maternal infection, especially with rubella, the German measles, as well as mumps. Then the majority of these congenital heart diseases are actually idiopathic, so we don't really know what's causing them. There are three predominant types. We have the left to right shunts, which are referred to as acyanotic. This is a misspelling here. This A shouldn't be there. So acyanotic congenital heart disease. We have those that shunt blood from the right to the left. These are known as cyanotic congenital heart disease. And you have those that are pretty much causing obstruction. So I'll begin with the easiest, which are the cyanotic. Remember that all of these are going to be beginning with T. What's the problem here? Deoxygenated blood from the right side, which is meant to go to the lungs, is pretty much going to be shunted to the left side of the body. So deoxygenated blood mixes with oxygenated blood. So this lowers the concentration of oxygenated blood on the left side. So the defects all start with T. So you have tetralogy of Fallot, transposition of the great vessels, truncus atriosum, tricuspid atresia, and total anomalous pulmonary venous return. Then, of course, this defect is going to be resulting in cyanosis, which is bluish discoloration of the skin and the mucous membranes. Or rather, it can be the peripheries, and it can be central cyanosis or peripheral cyanosis. But with the congenital heart diseases, remember that these are not going to respond so well to oxygen. Even the saturations will not improve significantly as compared to someone who has a lung pathology. If you give them oxygen, you will see that the saturations greatly improve. Then you have the acyanotic type, where here now you have these shunts that are pretty much taking oxygenated blood, shunting into the deoxygenated blood. But remember, this blood is eventually going to pass through the lungs and then it's going to be oxygenated. So it's not much of a problem, right? In the beginning, not really. But in the long run, remember now that the right side of the heart is going to be receiving more blood, and this is going to lead to certain adaptations. It's going to lead to hypertrophy. It's going to lead to dilatation of the right atrium and even dilatation of the right ventricle. And sometimes you may even get certain changes that are happening in the lungs, increase in the pressures in the lungs, pulmonary hypertension, thickening of the blood vessels, reduction in the lumen size. This can cause now reversal of this shunt, where now this initially acyanotic defect becomes cyanotic, what we call Eisen-Menger syndrome. So the defects are going to include atrioseptal defects, ventricular septal defects, and the patent ductus arteriosus. Then you have the conditions that pretty much cause obstruction, which is pretty much an abnormally formed valve or vessel that's going to lead to pressure overload involved in the atrium or the ventricle. This can lead to things like coarctation of the aorta, or can be caused by coarctation of the aorta, pulmonary stenosis and atresia, aortic stenosis and atresia. I really hope you enjoyed this lecture on the fetal circulation and a brief overview on the congenital heart disease. If you did, consider subscribing to the channel, hit the bell notification icon to receive notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.